Today we have three speakers. We will talk about how to detection the early gastric cancer, especially in Thailand. I will introduce our first speaker from Thailand. I think everyone may know Professor Ratakon very well. Professor Ratakon Virachon is currently the chief of the Center of Excellence in the Digestive Disease and Fecal Microbiota Transplantation Center of Thammasat University, and the secretary of the ASEAN's Stomach and Microbiota Study Group. He will deliver a talk regarding the gastric cancer in Thailand and how to screen and early gastric cancer in Thailand and what is the gap and how we select the two. Maybe I will introduce one by one because the next two speakers will come from Singapore. Please give a big hand to Professor Ratakon, please.
To be honest, sirs, we need you back to improve our quality of education. First of all, former President of GAP, Mr. Chairman, ladies and gentlemen, so my talk then touch on rethinking the gastric cancers in Thailand. What is the challenges, the evidence, and the new opportunity? I believe that the graduating is left have around 15 minutes in all the aspects. Paper of my contents going to consist of the current global and ASEAN's prevalence of gastric cancers, HP eradication for the gastric cancers prevention. What is the characteristic and the risk of gastric cancers in the Westerns and in the ASEANs? Screening gastric cancers in Thailand and ASEANs, what is to be appropriate? Updates on advanced management and future directions of cancers, these fatal cancers in Thailand and in ASEANs. Very first, we go to the global prevalence of gastric cancers. Gastric cancers is the number 5 of cancers in the world, and the number 4 of the cancer-related deaths in the world. And to be honest, it is the first leading object-related cancer, even worse than the hepatocellular carcinomas and pancreatic cancers. Going back to the leader ministers mentions the gastric cancer is a preventable public health policy. You can have a primary prevention, everyone knows very well. You can have HPV medications, we have to solve restrictions, we have to avoid the kinds of process. When you take high or fiber diets, and vitamin C from the foods can be very helpful. For secondary preventions, most of gastric cancers develop slowly on time. So if you can detect very early, it can improve the survival and reduce the mortalities. From the recent meta-analysis, they found that the endoscopic screening in the ASEAN country is associated to reduce gastric cancer mortality up to 40%. What is the global prevalence of these two cancers? You know the HP very well. The HP and gastric cancers will be correlated together. Gastric cancers can be happens in the Eastern Asians, such as China, Korea, Japan, in the Eastern Europeans, and in the South America. The global incidence, if you look for it in the Eastern Asians, is going to be 30 to 100,000. In the ASEAN, approximately to 7 to 800,000. Our important country is Thailand. Right now, we have around 70 million populations and gastric cancers. We're going to know what is the number of gastric cancers in our country. Gastric cancer is number 14. But even number 14, as mentioned before, most of the patients face with a very low survival rate, even 5 years survival rate, and very aggressive manifestations. When we look for the occurrence of gastric cancers in our countries about 22 years back, the prevalence in the male and female is going to be 8 to 9 and 100,000. But to be honest, the incidence increased with age. When you look for people who are more than 50 years, the cancer prevalence is going to be 10 to 100,000 in both sex. But when we look for the patients who are more than 30 years, you have to know right now we are in the elderly society. The gastric cancers in Thailand given more prevalence than many of the countries in the East Asian country. The prevalence is up to 50 to 60 in 100,000. What is the ethnic gastric cancer? You can see that many of you here are going to be Chinese. Even myself, I'm a mixed marriage. Thai and my mom is Chinese. If you are Chinese ethnic, the chance to be cancer is quite high. The adjusted odd ratio is 10. If you are in Thai Chinese, the chance to be cancer will be half, around 5. So summary, what is the gastric cancers in 2025? It's the 5th most common cancer worldwide. They have 1.1 million new cases and around 800,000 death cases. It's the first leading cause of GI cancer-related death. 3/4 cases in Asia, mostly in China, Japan, and Korea. In 2014, WHO published HPV eradication is a strategy for prevention of these fatal cancers. And since 2016, HPV infections classified of the early cancers. And we believe that if we know action for everything, in 5 years, 2040, we have around 1.8 million new cases and around 1.3 million deaths. How important of the early screening? Early screening can save life. You can see in many countries, just like in Japan and South Korea, they can have endoscopic screening. The 5 years early is quite better compared to many ASEANs, even in Singapore and Thailand. We are in the worst numbers of 5 years early, even less than 20. And early screening is not only to improve the survival, it let you have a chance to detect the early stage. Early stage, it's been better survival outcome. Late stage, it's been very poor 5 years survival. I think this is one of the important slides. Our sponsor of the symposium, if you have a positive of the gastroclear test in the selected test, I think the Ministry of Health of Singapore is going to cover the expense for the upper endoscopy. I think Singapore is going to be one of the leaders countries for the gastric cancer screening, even in our ASEAN. And yeah, last month I got a chance to visit Mercer's Lab Singapore in 2019, and believe that is an international standard of lab in many modern molecular lab tests here. We'll be back to the stomach cancers in Thailand for many years back. We grabbed around 100 patients with gastric cancers in Thailand. The mean age is going to be 55. The common presenting symptoms not only dyspepsia but weight loss, anemia, and anorexia. Very interesting, right? The 5 years survival and 1 year survival is quite low. The 5 years ago is only, the 1 year ago is only 43, and the one live until 5 years. When we look for the gastric cancers again, why they have a very poor 5 years ago, then we can see that most of them presented with a very advanced stage, just like stage 3 and stage 4. And again, gastric cancer is not only the disease from the old, but right now we come up with many patients with the young. We just published many years back with gastric cancers in the young, and we found that they have many severe manifestations. We know that gastric cancer in the elderly, most commonly found in the male. But when we look for the patients who are in the young, the gastric cancer is come up in the female. You can see that the 3/3 of the patients in the female, if the age under 40, then just 1/4 is going to be male. And most of them, I have to say, is around 1/3 going to have a family history of GI cancers. And again, why they have very poor prognosis? Because most of them are going to have a diffuse type of cancers and very advanced in stage. 5 years ago, even less than 10%. And our recent publication, Dr. Kubadi is a junior colleague in Thammasat University, just published a predictive factor associated with survival of female gastric cancers in Southeast Asia. We grabbed around nearly 1,500 female gastric cancers in ASEAN and approximately 100 female gastric cancers. The top 3 with the highest incidence of female gastric cancers is Indonesia. Wow, I think it's a very interesting point because we know that Indonesia have a very low of gastric cancers, but the high number of the female gastric cancers. Thailand is the second and Singapore is the number 2. The important things, the median survival, if you have gastric cancers less than 50 in ASEAN, the median survival is just only 8 months, quite less than a year. What is the predictive factors? We found that if you are the patients with cancers, with this fatal cancer is less than 50, you have a diffuse type and you have an advanced stage, that's going to be a very poor prognosis. Right now, we are in the pre-cancerous conditions. We have many machines, just like NBIs, BLI, LCIs from the many companies. We can detect a lot of pre-cancerous lesions. I think this is very good publications in BMJ 2015 about the risk of cancers during the 20 years of follow-up. In the lowest country, it's 400,000 cases with the endoscopy and biopsy. It's just like in many answers, we are in the low prevalence of cancers. What is the chance when you have the pre-malignant conditions go to be the cancers? If you are normal mucosa, it's going to be 1 to 56. If you have a chronic gastritis, it's 1 to 85. If you have an atrophic gastritis, it's 1 in the 50. IM, 1 in the 40. And the last, this patient is 1 in the 20. If you follow up to 20 years. I think this is going to be very important as might be a policy. When we take a look in the very current update, we have an Asian-specific associated of gastroenterology, APAGE, the false recommendations on the surveillance of HPE-associated gastric pre-malignant conditions just published in Gut last month. And we have a Type A consensus, and we have many publications in our regions. This is my personal perspective. I think that gastric cancer screening and HPE treatment in ASEAN, we cannot do for everyone. We might focus recommending a gastric cancer risk reduction strategy in the high-risk population. Who is the high-risk population? Just like the first family member of gastric cancers, is a certain ethnic groups. You have to know that Chinese, I think it's going to half of these groups going to have a Chinese blood together. And the HP treatment for the gastric cancer prevention is most effective before the atrophic gastritis have developed. To be honest, it's around 10 to 20 years before I take off of the gastric cancers. And I have to say that HP treatment for prevention of gastric cancers, the earlier is the better. And I have to say that the earliest is might be the best. And we have to consider HP eradications in all pre-malignant conditions. What is the update management? I can take a chart for update of the important cancer. The surgical innovations right now, everyone's going to go to the minimal invasive techniques. We have robotic surgeries, we have anti-reflux procedure of the proximal gastrectomies, we have a combined endoscopic and laparoscopic surgery. For the chemotherapies, the baseline is going to be FLOT, 5-FUs, lincovolins, oxalopatins, and docetaxel. This is going to be the standard perioperative. And the combined therapy together with the platinum-based doublets or triplets is going to be make the survival is going to be better. What is the immunotherapy? They're going to have a transformed gastric cancer treatment. This is a paradigm shift. Immunotherapy has emerged as one of the most transformed treatment approaches to gastric cancers. Move from the late line to the front lines. And the mechanism of action is going to be the checkpoint inhibitors to remove the brake on the immune system, allow T cells to recognize and attack the cancer cells. So just a publication many months ago in New England Medicines, the preoperative of the durvalumab for the treatment of proximal and distal gastric cancers have a promising data to improve the survival. And durvalumab is just like anti-PD-L1 antibodies. Mr. Chairman, ladies and gentlemen, to come up, what is the future directions and emerging therapy? I have to say that early detections and prompt management is maybe key to important factors for treatment of these fatal cancers. Appropriate gastric cancer screening and considered test and treat HPE in the high school is very important. And the last piece, the new effective therapies are currently in the drug development pipeline. Thank you so much indeed for your kind attention.
Thank you very much, Professor God, for your informative talk. So I will go to the next speaker, Professor Adjunct Assistant Professor Dr. Kevin Cole. Dr. Cole now he is an Adjunct Assistant Professor of Medicine at the National University of Singapore and a gastrologist practicing in Granny Eagle Hospital, Singapore. He will talk about the three phases of the critical development of the process of the gastroclear with an emphasis on the prospective validation study and the test performance in an average risk of the Asian population. Professor, how we go to the stage. Thank you.
Thank you for the kind introduction. Good morning. So today I'm going to speak on the understanding the clinical development as well as assessing the performance of this test, GastroClear, which is a microRNA-based cancer screening test. In fact, probably the first test in the world for this kind of cancers. So these are the disclosures. I was forming part of the team which subsequently we'll be talking about gastric cancer in 2025. I think most of this has already been covered in the previous talk, so I can breeze through those slides. We'll talk about screening and detection of early gastric cancer. We'll talk about microRNA, why we use microRNA rather than other tests. And lastly, we'll talk about the development and validation of this test for the detection of gastric cancer. So this is a case Professor Wee. So a 60-year-old gentleman with dyspepsia and previous Helicobacter positive. So you can see this is a scope done, and you can see on the greater curve there is what appears to be an atypical polyp. Actually looks a bit more like a hyperplastic type of gastric polyp, which is, you know, is potentially pre-malignant. But in this case, the AI system, which we had at the same time, suggested that it was actually early gastric cancer. You can see this is the little bar at the bottom. It's early gastric cancer. And so it was removed. And you can see the histology actually confirmed that it was actually moderately differentiated adenocarcinoma on this biopsy. So where we are in gastric cancer in 2025, as mentioned, is the 5th most common cancer in the world and also the 5th leading cause of cancer death worldwide. It's more common in East Asia, Central, Eastern Europe, Central and South America, mainly in Asia. You can see the age standardized risks of some of the more common countries. You'll see, for example, the highest risks in Mongolia, Japan, Korea, China, with you see Thailand being relatively low on the incidence rate. And the other point is that gastric cancer survival is relatively poor. If you look at the international survival rates compared to some of the many cancers that we have, for example, breast, colon, rectum, all have more than 50% 5-year survival rates. Conversely, gastric cancer, you can see globally has about 1/4 survival rate, but which is a shame because often it is 95% 5-year survival rate diagnosed at stage 1, but 5% is diagnosed at stage 4. So there's a dramatic shift from early to late stage in terms of survival. This is the local data, I think it's been presented. And this is the other point that I also wanted to make, which has also been discussed, that as we age, the risk of gastric cancer goes up. In fact, the risk of gastric cancer at 80 is about 3 times that of the risk of gastric cancer at 50. So it's something to kind of bear in mind as we deal with older patients who may not be necessarily keen for evaluation, but that is precisely the group that actually needs the evaluation. So this is something to bear in mind. So next we'll talk about screening and early detection of gastric cancer. It is strong evidence that gastric cancer screening improves survival. This is mainly from the Japanese data. You can see the 5-year survival of the screened versus unscreened. Basically, we have doubling of the survival rates in the screened population from Japan. And this is the similar data from Korea, where they also have a screening program. Looking at you can see the odds ratio. It almost appears about halving each time you do a screening scope. You can see the odds ratio of dying from gastric cancer halves with the first scope, and then again almost halves with the second scope. So Korea and Japan are very high risk prevalence populations, so endoscopic screening is justifiable. But for intermediate and low risk populations, which is a lot of the world, we have to think about other strategies, in which case we may not be able to screen the whole population endoscopically. So we are left with endoscopy, which is invasive, has a expensive and has a lower uptake, versus a blood test which is non-invasive, potentially cheaper and can be implemented in a wider population. So this may be something that's potentially more cost-effective in a low-risk population. Next, we'll talk about microRNA. So microRNA is a small non-coding RNA molecule, generally about 22 nucleotides, 20 to 22 nucleotides in length, and it's usually used in signal transduction. So it's the equivalent to the short interfering RNA in plants. So it is suited for cancer diagnostics because it is an active regulator of cancer progression, and it's highly accessible, it's present in the blood, and you don't need a lot of it to assess. And this is clinically what it looks like, and these are the actual sequences used in some of the tests. And unlike many of the other early cancer markers on the market, microRNA is actually actively secreted by live tumor cells. whereas circulating tumor DNA is actually passive release by apoptotic tumor cells, and circulating tumor cells are basically metastatic tumor cells. So by the time you see circulating tumor cells in the blood, often it's already metastatic, stage 4. So this is how the blood biomarkers for gastric cancer compare at the current moment. You can see generally, although there are many biomarkers such as CEA, CA19-9, they're not in widespread use because the sensitivity and specificity are not great, except the microRNA panel, which we'll discuss today. And so that brings me to the development and validation of the microRNA test for the detection of gastric cancer. So now many tests in the market have a discovery phase where they look at and develop the test, and a validation phase where they basically look at how the test performs. But I think GastroClear is unique in the sense that it's got a discovery phase, it's got a verification phase where they confirm what they looked at, and also they implemented or kind of validated this in a larger cohort. So it's like a 3-step kind of process, which is medically more robust than a lot of the existing tests that we have in the market. So for the discovery cohort, there were 2 prospective studies, the Dec Symp cohort as well as the GasCat cohort, and basically they looked at 500 over candidate microRNAs and selected a subset, discovered 75 that were dysregulated in gastric cancer, and of these 75, they subsequently chose 12 of them for verification. You can see they verified them with 2 separate populations, one cohort from Singapore and one cohort from Korea. And they used it as a case control design, looking at asymptomatic patients as well as newly diagnosed gastric cancer patients, including cancer patients with non-cancer controls with intestinal metaplasia. So you can see this is the optimized biomarker panel to get the ideal sensitivities about 12. And you can see this is the area under the receiver operating curve, showing that this test is relatively good sensitivity and specificity of this 12 microRNA panel. So you can see this data for the test results of the risk stratification. Looking at, and the one thing to note is that the performance is actually quite good even in the early stage, which is really where you want to pick up more patients. It's not good enough to pick up patients in the late stage because that would be not make much difference in terms of the care. But you really want to kind of bring the needle forward and pick up these patients before they are symptomatic and when treatment is much more successful. So like any test, there's always a balance between the low and the high cutoff value. So GastroClear itself doesn't tell you whether the patient has gastric cancer, it gives a risk score. And so the risk score has a certain threshold, and it's actually calibrated to have a relatively lower threshold so that you can pick up more patients and miss less patients as a rule-out test. So any test is always a balance between the sensitivity and specificity, and the way GastroClear does is it basically classifies patients into low risk, intermediate risk, and high risk groups. So this was subsequently validated in about 5,000 patient cohort, looking at the 12 microRNA assay, and you can see this is the study flow, and this 3-tiered classification together with the patient risk profile gives a better risk stratified management in terms of detection of gastric cancer. And you can see this is superior to existing blood-based biomarkers, as well as retains robust sensitivity across the stage. So you can see that even in stage 1, which is hardly anything clinically, you'll be able to detect it with 85% sensitivity on the blood test. And there's also robustness by tumor size and detection by subtype. So you can see that overall the test performs reasonably well in a validated population, and also stable across age range, histological subtype, ethnicity, and gender. So these are important subtype factors that often vary for certain blood-based biomarkers, but in this case, GastroClear seems to have relatively consistent performance, which is something that you want for a screening test. The next question would be, what if the signal comes from other cancers? As no microRNA is upregulated in certain cancers, and so this is a test looking at some of the other types of cancers to show that basically most of the time, if the signal, at least from GastroClear, comes specifically from gastric cancer. So this is what the test looks like in terms of the test kit. And it's in terms of regulatory status, it's approved in the EU in 2017, 2019 locally, HSA, Singapore HSA, and US FDA Breakthrough Device Designation in 2023, as well as the Thailand FDA in 2023 as well. And recently also received the China NMPA approval. So it's something that has been recognized by multiple authorities as well. So this is the current risk stratification and the approach in terms of its intended use. Basically, you look at the population at risk and then have a blood draw and run this test. And depending on the risk stratification, if they are high risk or intermediate risk, you may want to consider gastroscopy. And if they're low risk, and then you basically go back to surveillance. So this is the potential workflow and how it can be used. So there's one slide about other tests. For example, you may see some of the other tests being on the market, such as circulating tumor DNA. And there are multi-cancer cell-free DNA or circulating tumor DNA tests purporting to detect early cancers. But if you look at the actual technical details of these tests, the detection limit is 0.1, what they call VAFs, or variant allele frequency, which is often, these are the more sensitive tests, and some of the tests detect up to 1% variant allele frequency. This means for an 80 kilo person, they're detecting a tumor that's estimated 80 to 800 grams, which actually is probably not going to be early stage. So even though they purport they can detect cancer early, you really have to know what sort of cancer they're trying to detect and at what sort of size you're dealing with. So in conclusion, gastric cancer remains a clinical problem, with early detection being key to better survival. MicroRNA biomarkers have advantages being stable in biofluid as well as robustness in assessment on qPCR, and its role in cellular transduction and regulation make it a useful test in cancer screening, including in early stage cancer. And to conclude, a test panel of 12 microRNA blood has been developed and subsequently validated in a large clinical cohort and developed into a first-in-class blood-based screening test with regulatory approval in EU, Singapore, FDA, Thailand, as well as China. Thank you.
Thank you very much, Kevin. Maybe I will leave a Q&A at the end of the session. Thank you for your excellent talk about how to detect the early detection of the gastric cancer by using the GastroClear tools. The next speaker will be from Singapore as well. Adjunct Associated Professor Wee Hogan is my best friend. Actually, Hogan now he is practicing at the Grand Eagles Hospital in Singapore as well. Hogan undertook the further training in UK and Canada and was awarded the PhD from the University of Sheffield for his thesis on the post-infectious RNAs, and he also was a past president of the ANMA as well. Today, we will share a series of the real-world case describing of the detection of the early gastric cancer and high-risk region in individual whose elevated GastroClear scores prompt diagnostic endoscopy. Ladies and gentlemen, please welcome Hogan Wee.
Very kind and friendly introduction. I don't have a disclosure slide, but just to show you that I'm more of a practicing clinician now. I still have an adjunct program, but I continue to take active interest in research and research methodologies. And it's from that perspective that I've applied it to many of my clinical situations. So continue to use that when I look at patients. So my sharing today is how I use GastroClear in my real-world experience. It is based on about 100 tests in 12 months. And this is done in a private hospital, so our numbers obviously are not as big as some major hospitals in Bangkok. So it might be a bit tedious, but it's more clinical. And then I don't have a clear, easy answer for all of you for every situation. It's more actually for provoking interest and thoughts. So first case is a 50-year-old female Singapore Korean Chinese who was quite well nourished and is a little bit plump. She presented one night to the emergency room with 3 weeks of recurrent abdominal pain and fever and vomiting on the day of admission. So, but prior to that, 2 to 3 months before, she had actually been having what her doctors, the general practitioner thought was acid reflux. I don't know if it's the same in Thailand, but in Singapore, everybody who goes to any doctor with any GI complaint, even diarrhea, is told to have acid reflux and just given PPI, which I think is a bad practice because it hides a lot of the possible cancers. So anyway, on admission, I just didn't feel like she had a simple reflux, so sent her straight for CT scan, and they showed up the soft tissue mass adjacent to the gastric cardia. So proceeded to do an endoscopy and found circumferential cardiac tumor about 3 centimeters, and then biopsy concluded as adenocarcinoma. So ideally, this should have been picked up even earlier with the use of gastroclear, but this is a real world experience. We've only just really been, or at least for me, I've only been using gastroclear in the last 2 to 3 years. So then I thought, why don't I just test her with a gastroclear and see what's the number, and true enough, it was really high. So 89, 90 is way over. High risk is considered anything above 50. And subsequently went to oncologists. Oncologists did some testing and found that she has this ATM germline mutation present. I'm not a scientist, so I can't really tell you much about all these mutations, and not even much about microRNA. So I'm hoping that as we go along, we can have some discussion how we as clinicians can make use of knowledge to help the patients. So germline mutation, ATM mutation I found is involved in DNA damage signaling, and this affects microRNA expressions. And I learned that gastroclear panel actually includes at least two microRNAs that are involved in that are affected by this ATM mutation, as you can see there. So the question I had in my clinical question, I do not have an answer, is whether we can use this as a number 1 prognostic marker, or number 2 as a measure of clinical therapeutic response after treatment. So this is up for discussion. My oncologist friend cannot give me a clear answer, but I'm hoping some scientists can help to give some direction. So case 2 is a patient with severe atrophic gastritis, a youngish male Singaporean Chinese again, who again was presenting with more like reflux type symptoms and dyspepsia, but on his first endoscopy found enteral intestinal metaplasia with moderate atrophy, mild reflux, duodenitis, but was already H. pylori negative. And then since then he's been followed up regularly, except for there was an interval during COVID and all work seemed to stop. So then he came back for a review in November 2020 after COVID he stopped, and then had another scope and found this time to have severe pangastritis, blood erosions, and chronic atrophic gastritis got even more severe, and was found to have a histology compatible with autoimmune gastritis. As you learned from Professor Ratakon earlier on, these are high-risk indicators for gastric cancer. So he continues to have recurrent abdominal discomfort and belching, and fortunately or unfortunately, he has an anxious personality. So he keeps coming back to me and asks to do endoscopy. So this gives me a chance to track his progress and also at the same time to apply gastroclear to understand how gastroclear may help us understand progression to gastric cancer or not. So with that histology, then also I went to do the antiparietal cell antibody was positive. So over the years, we've been tracking him through blood tests, and his ferritin level was initially low by our standards. It's for men as well, so it's consistent with his atrophic gastritis. And then I only started applying the gastroclear test in 2022. As we said, although I think gastroclear So how I treated him was with probiotics, iron, vitamin B12 folate supplement, and amitriptyline for his anxious personality. I think to me, what may have helped benefit him is to restrict PPI use. And just general dietary advice as you learned from Professor Rutherford earlier, avoid salt, preservatives, chemicals, alcohol, smoking, all that stuff, right? So I think with atrophic gastritis, we need to emphasize that we should try to manage our use of PPI because I think it's going to make it worse. So you've seen probably this already from Professor Kelvin's talk. Just want to highlight how do we use it. We need to understand the population in which we have applied this test. So going back to the pivotal study, they really studied relatively high-risk subjects. That means these are all Singaporean Chinese in the discovery cohort. And elderly, that means 50 and above, and attending gastroenterology clinics, suggesting that they already had symptoms or have concerns about gastric cancer, and thus were willing to undergo this kind of close regular monitoring. Then also looking at the kind of histology in the discovery cohort in the beginning, intestinal metaplasia was relatively common whether the patient had cancer or not, so that tells you it's a relatively high risk population. But interestingly, for gastric atrophy, those who had cancer actually had less likely to have atrophic gastritis. So the relevance of this for my patient with this atrophic gastritis, I'm uncertain, honestly. So case 3, I said I have more questions for you than answers. My case 3 patient is a 54-year-old Chinese national, so he's from China, but living in Singapore for a while, but still very much retains his China roots or his China cultural as well as historical background. So long-standing dyspepsia. 2014, he was diagnosed in Beijing with gastric ulcer and Helicobacter pylori. Then came to Singapore in September and asked me to do another scope, and then we found that confirmed he still had H. pylori infection and extensive intestinal metaplasia. Then he was lost for about 4 years and came back in 2018 and found a moderate degree of dysplasia on some of the gastric biopsies with atypical intestinal metaplasia. But this time was H. pylori negative. Despite that, given the limited options of what to do with this dysplasia, we gave him empirical vonoprazan triple therapy. So July 2020, there seemed to be some improvement. We didn't see dysplasia, but his OGIM score for gastric intestinal metaplasia was at the highest end of the scale. He was H. pylori negative. In 2022, his H. pylori came back. So probably the earlier scopes and biopsies had missed it because it was at low bacterial count. So in 2022, he had H. pylori again and extensive intestinal metaplasia. So because of that, he got anxious, and so after 6 months, we did it again, and still had H. pylori gastritis, pancreatitis, but after that treatment between January 2022 with H. pylori antibiotic treatment, and then to July 2022, the intestinal metaplasia seemed to improve or reduce. So then I started using GastroClear because it was just coming too often to do his scopes or asking to do his scopes. And it started off at low risk, that means below 40, and then we paused it for a while. Then in December 2023, it went up to 46, intermediate risk. So then January 2024 came back to do his scope, so H. pylori is still negative and just only focal intestinal metaplasia. So looking at the rate of his GastroClear evolution from July 2022, 35, December 2023, 46, and then 2024, August 39, and February 2025, this year, 43. So this year, February, we did his endoscopy, and it was H. pylori negative, mild to moderate, focal erosion, intestinal metaplasia, and his OGIM had downstage to 2 after all the repeated Helicobacter treatments. So in a way, in this case, I'm using the GastroClear to remember I showed you the discovery cohort, the majority had intestinal metaplasia regardless whether they had developed gastric cancer or not. So learning from this too, and also from real-world patient experience, it doesn't seem like GastroClear is an effective test for detecting gastric intestinal metaplasia. So I think it's really more to manage patients' anxiety, because at least in Singapore, our guideline is if you have gastric intestinal metaplasia, you repeat your endoscopy after 3 years. But in between the 3 years, the patients are like worried, what if something pops up? Because to them, when you say intestinal metaplasia is pre-cancer, they think it's 100% tomorrow they get gastric cancer, but it's not. So you've got to manage the risk. And one day will be to use GastroClear as a way to reassure them. So I do it like every 6 months. Okay, so finally, case 4, 51. I just saw her this month or last 2 months ago. 54-year-old Japanese female, asymptomatic, annual health screening she did and found that her GastroClear was 43.5 and the CA99 was 60, which are both above the threshold levels. Looking back in 2023, she had already done a routine endoscopy and found an enterogastritis, but it was done as a routine by a general surgeon, so he didn't really take a lot of biopsies beyond removing the gastric polyp. And then in 2024, despite not having Helicobacter detected at the screening endoscopy, in that screening endoscopy, she underwent urine breath test on her own accord to assess her risk, because she's Japanese, and it was also negative. So then she had done her first GastroClear test in 2024 with a health screening center, and the GastroClear number was only 28, and her C99 was only 40.7. Okay. So remember, she had her index endoscopy in 2023. Then in 2025, in her follow-up health screening, suddenly the GastroClear went up, and the C99 also went up. So she then was sent to me, and then I'm thinking like, what should I do? I mean, endoscopy 2 years ago was perfectly normal, so it's not so likely that she's suddenly popping up some early gastric cancer. So anyway, I repeated the test, and unfortunately it went even higher. So no choice, we need to do the endoscopy. When you do endoscopy, I'll return and found minimal gastritis, only small polyps, Helicobacter urase test negative. So the gastric biopsy, very non-diagnostic, I mean, very flat. Minor mild chronic gastritis, no changes, holding score was 0, OGA score was 0. So what do we do with this patient? So going back, you see again, you saw this chart, that actually you can combine various blood markers or serological markers to assess the person's risk. We saw CA99 is very overall specificity is high, but sensitivity is low. So that if it's really sky high, then it's quite specific. Whereas this is a good balance. So you can always combine them as the Japanese do with an ABC method. That means you can use multiple tumor markers plus the GastroClear test as a way of better evaluating your risk. Then also remember, you saw this slide that GastroClear, well, is a lot of specificity for gastric cancer. It's not 100% specific, so there could be other cancers, as you saw from Dr. Goh's presentation, that also could have a positive GastroClear test. So with that in mind, then I sent this Japanese patient for a CT scan to look for all these various other sites that could possibly have cancer. So she underwent a CT thorax, abdomen, pelvis, lungs, a lot of small non-specific nodules. As you probably know, when you use AI for CT lung, you get a lot of small little things that you don't know what to do about. Liver had a few small cysts, and then left kidney small cysts, colonic diverticular, uterine fibroids. So what to do? What's the next step? Even though she had a colonoscopy 2 years before that was normal, I think the next step I will still have to ask her to do a colonoscopy again. So in conclusion, how should we use GastroClear? This is from our first author, Professor Jimmy So, of the pivotal developmental paper for GastroClear, to share his insight that any test when false positive, and it sublime clinical review. As clinicians, we still have a role to play to guide the patient what to do, when to do, and how to interpret these tests. So he thinks that gastroclear is a useful option for symptomatic patients who just do not want to do a scope, to push them across to do their scope. But in clinical practice, I found that you could use it for various other clinical situations that could prove to be helpful in the future. I think to conclude how we should position gastroclear, we need to think of where we are applying it. Is it in a general health screening? So keep in mind that in Thailand, maybe the risks are low, and then in Singapore, it's a moderate risk, and that the discovery cohort were relatively high-risk patients. So probably it's better for screening at high and risk populations. I use it as a tool to reassure patients, as a way of using a non-invasive monitoring for patients in between what they perceive to be high-risk situations. And then I think we have to grapple with how to deal with false positives and how to learn how to look elsewhere. I think some unanswered questions are like, are there other cancers that could be showing up with the gastroclear, but also whether there are other contexts. Because in our past experience with other tumor markers, inflammation can tend to drive up some of these inflammatory markers. So we need to know whether this can be a possibility so that we can provide patients with a better explanation for their test results. Thank you very much, ladies and gentlemen.
Thank you very much, Program, for your superb talk. Now I think it's time to for Q&A session. Please come to the microphone and identify yourself and ask the question. Any questions from the floor? Okay. Rosa, please. Somebody could check the microphone for the machine.
For buried esophagus, we can do ablation in high-grade dysplasia. For the patient with intestinal metaplasia which looks like not good, can we do the ablation like in the buried esophagus?
Kevin, do you want? Yeah, maybe come to sit together with me. And maybe leave the microphone portable and okay. Go ahead. Come to sit.
Thanks for that question. I think right now the evidence for ablation or basically mucosal ablation is more for dysplasia. In other words, if there's this plastic gland seen on the biopsy, and you know the particular area that's dysplastic, you probably either try to destroy it from various ways. Either you can do an endoscopic mucosal resection, or you can do an endoscopic submucosal dissection, an EMR or an ESD of that particular area. But to my knowledge, I think there's no preventative method for so-called high-grade intestinal metaplasia. Bearing in mind that intestinal metaplasia is actually quite common, can be as high as up to, depending on the population, can be as high as 30% of the population, depending on your, of course in Singapore we are high risk. So the actual progression from intestinal metaplasia to cancer, the absolute number may not be very high, and so therefore to systematically ablate some of these would be a bit, I think, much. But thanks for the excellent question.
Yeah, another comment, please.
Professor Nishit, I think you grasped the very important questions. They have just a publication from APAG Task Force Guideline in GAP last month, and they mentioned that dysplasias in the stomach is quite different from dysplasia in the esophagus. We mentioned it's just like the low-grade dysplasia. Low-grade dysplasias right now is not only the dysplasias, you have to monitor every year. For the high-grade dysplasia, you have two kinds of high-grade dysplasias. The one is visible high-grade dysplasia, you have to remove it, you have no choice. The second one, if the high-grade dysplasia is non-visible, to be honest, you have to grab the HPV medication and monitor every 6 months. So right now, I think it's going to be different. And a very interesting point is that the APAG Task Force Guideline, we have to do the gastroscopy. Argentina, how long we do the gastroscopy? So we do very fast. How we do 3-5 minutes, something like that. And for the colonoscopy, you have to do at least 6 minutes for the withdrawal to make sure that you grab everything. But right now, it's the APAG Task Force Guideline mentioned that you have to do the gastroscopy along with the image endoscopy for 7 minutes. It's quite long. but this is standard of care very soon.
Okay. Maybe coming back to gastro care, I would like to ask Ed that you already mentioned that when have an elevation of the gastro care, other conditions not only for the gastric cancer but also the like colorectal cancer or even the renal cell carcinoma also can raise. Any benign condition can have an elevation of the gastro care value. Yeah.
Excellent question and very challenging. I don't think we have data on that because so far most of the research is based on just gastric cancer and patients at risk of gastric cancer. But certainly, I want to know as well. And for this one, I think we need a scientist who's more familiar with microRNAs. I don't know if the company has anybody who could share some insights because you have your scientists, right?
You want to share?
More about like microRNAs.
Okay.
Yeah, so good morning everyone. I'm Sakti, the Mental Science Liaison from Mirtex. To answer the question with microRNA, so broadly speaking, microRNAs they are expressed in various cancers, and especially because since cancer is primarily an immunological disease, whether it's a hot tumor or cold tumor, so there is an elevation or downregulation of microRNAs. But what in the gut paper has shown is that from when they did the discovery phase screening, they found 1 in 500 microRNAs, and then they filtered it down to 75. And then through the use of algorithm, then they found 12 microRNAs that are specific for gastric cancer. However, like what Prof. Wee was saying, from case 1 there were 2 microRNAs. So even though if those 2 microRNAs were somewhat elevated, you still have the other 10 microRNAs that is specific for gastric cancer.
Okay. Yeah.
Thank you.
Okay.
For the gastro care, the important question right now in Thailand, 5 years back, we have a national survey for gastric cancer, pediatric conditions. And we found that most of the patients that have cancers, but we have a dysplasia, even low-grade and high-grade dysplasias. From maybe go ahead and cover in just brief questions. For the gastro care, they have some evidence at least to help to clarify that the patient have a risk of the high-grade dysplasia. Please.
Thanks for the question. I think for hybrid dysplasia, I think as the data shows, gastrocare actually is not so good in terms of performance because the test is basically optimized for cancer rather than dysplasia. So every test you have to kind of tune it to perform best in a certain condition. And the original intent was to pick up gastric cancer early. So in terms of dysplasia, the data shows about 60% sensitive only. So it's not good enough, I guess, in terms of dysplasia.
One last question. In Thailand, we have a lot of stomach cancer in advanced stage, and somehow we want to get it early. About the gastrocare, they can classify us to pick up the case with early and late cancers, which is different or pretty much the same.
Thank you. So I think in terms of Thailand, it's precisely things like gastrocare that will be a bit more helpful because we know that the incidence is not high enough to justify population level screening. So you need to basically look at the higher risk individuals, and then you want to do a easily done non-invasive test to risk stratify. Then of the higher risk on this risk stratification, then you can do endoscopy. So if you're doing a systemic population level kind of evaluation, this would be probably how we want to consider doing it.
Maybe last question, do you have any data comparing with the gastrocare if they're positive? Will they go to send to undergo EGD, comparing with the EGD alone? I mean that in terms of the cost effectiveness, because now you recommend that like a screening to did the gastrocare. If they have a positive test, we send the patient to the upper endoscopy. But because of Thailand, we quite easy to access the upper endoscopy. If we do only upper endoscopy in terms of the cost effectiveness, maybe coming first.
Because in the original paper, they do have cost benefit analysis and
Yeah, so in the original paper we did publish cost effectiveness, but I think the costs at that time were reported were relatively different from what it is currently. So I think cost effectiveness is something that is very contextual. So what is cost effective in Singapore may not necessarily be cost effective in Thailand because of different costs. So the gastroscopy cost, the test costs. But I think the intent is that with increased use, the GastroClear price would probably be able to be at a level that is acceptable and will be cost effective. So I think that's something that is in the future. But right now, as it stands, I think the paper did conclude that the GastroClear was cost effective in the Singapore context for certain price points. So whether that applies to Thailand is a different story, because of course everything in Singapore is expensive. So
Okay, you want to add on any short answer?
I think it's a very exciting test, and we will learn more about it once we start the review. So it would be nice to have a prospective study in a real world setting to see how it involves this test.
Okay, I think we come to the end of the session. I would like to sincerely thanks Professor Dr. Karinko and Program V for a very informative talk today, because for the tools for the early gastric cancer for Thai people. And I'd like to thank Lasix again from Singapore for supporting this 110%. And I would like to call this session closed. Thank you very much.